Hi everyone. Today I'm going to speak to you on TLD transition in our region. That is a combination of tenofovir, lamivudine, dolutegravir as an universal ERT regimen. At the outset, I'd like to thank the organizers of this Bangkok Symposium for inviting me to do this presentation. So we all know that these are the various antiretroviral drugs approved by US FDA for therapeutic use in managing people living with HIV. And also, most of these medications have been available in our region and we have been using in our clinical practice. These two landmark clinical trials called HPTN 052 and START really completely changed the treatment and prevention paradigm in HIV. So today, based on the outcome of these two studies, today everyone who has been HIV positive, irrespective of the CD4, be initiated on antiretroviral treatment. To do this, we need the best antiretroviral combination, which is convenient, less toxic, and safer to our people living with HIV. Also, the treatment guidelines went ahead in recommending two different ways of initiating treatment. One is rapid ART initiation, that is someone who is HIV positive, if they have any comorbidities, initiating ART within 7 days, and people who have been totally asymptomatic and prepared to initiate ART treatment, you can even initiate treatment on the same day. Again, to do this, you need the best drug, which is tolerable and convenient to our people living with HIV. So this is a natural history of HIV treatment guidelines developed by WHO and subsequently been adapted by various regional guidelines, where you can see this in the year 2016, a combination of tenofovir, lamivudine, and efavirenz was preferred, and the alternate being a combination with tenofovir, lamivudine, dolutegravir. Why in 2016 this alternate regimen was brought in, to cover up, efavirenz containing regimen is based on the retrospective review of these 4 different NIH-supported ACTG clinical trials. So what are those trials? You can see all those numbers: ACTG 5142, ACTG 5175, which was predominantly done in resource-limited settings. Here again, in our region, India and Thailand participated, and also a couple of other studies where the study participants used efavirenz and they were being compared with other non-efavirenz containing regimens. So in these particular retrospective review, what's been found in that is patients who have been enrolled in these clinical trials, they have 2.6-fold higher risk of attempted or completed suicide among those who are assigned to efavirenz. And again, today we are talking about starting treatment for everybody, irrespective of the CD4, who are totally asymptomatic. Even on the same day of HIV diagnosis, you need the best regimen, which has been tolerable and less toxic to all people living with HIV. Again, this is the data from WHO following various surveillance among different countries where they have been initiating treatment, where they have used NNRT-containing therapy in the past. But if you see this graph, where you can see the baseline prevalence of NNRTI is being increasing to more than 10% in many of those countries in sub-Saharan Africa, and as well as it's been going up even in our region. And if you see this in our region, in India, it's anything from 5 to 10%, in Thailand around 8%, and in Asia 4%, and Philippines almost 9%. Again, in our region, the baseline NNRTA resistance is catching up, is almost touching 10%, where again, a combination with tenofovir, lamivudine, efavirenz may not be applicable. Following these surveillance data, WHO developed a guidelines of using non-NNRTA containing therapy, that is with the dolutegravir containing therapy, especially in regions where they have more than 10% baseline NNRTA resistance, where most countries will belong to. And why these dolutegravir being used? Again, it's based on evidence from different clinical trials, starting from Single, Flamingo, Spring, and Sailings. But again, if you see this one particular study of Single, where they compared efavirenz containing therapy versus dolutegravir containing antiretroviral therapy with 2 NRTIs among patients who are initiating therapy, where it very clearly shows that a combination of 2 NRTIs with the dolutegravir is superior to efavirenz containing therapy. Also, all these different clinical trials have shown superior efficacy of dolutegravir with 2 NRTIs as compared to raltegravir or darunavir or any other 2 NRTIs containing therapy. Also, these studies have very clearly shown that a combination of 2 NRTIs and dolutegravir is being having a high genetic barrier in terms of resistance. And also when they looked into the tolerability, particularly when they compared efavirenz versus dolutegravir, and participants who are on efavirenz containing therapy, they tend to discontinue regimen because of various CNS toxicities like dizziness, abnormal dreams, and insomnia, as compared to dolutegravir containing therapy. Again, a combination of 2 NRTIs and dolutegravir is being generally well tolerated as compared to other regimens, which have been used in these clinical trials. And again, when we talk about a combination antiretroviral drug in a resource-limited setting, this should fit into all population: adults, adolescents, children, pregnant women, as well as patients who have comorbidities. And again, tuberculosis is one of the most common opportunistic infections in resource-limited settings, again, particularly in our region. Again, the combination of TLD should also fit well with anti-TB medications. Here again, this was well proved in a study called Inspiring, where they have shown that doubling the dose of dolutegravir when they have been given along with the rifampicin-containing therapy will achieve this therapeutic level to suppress this virus. And following this, the recommendation came when you have been initiating someone who having TB, when they have been initiating rifampicin-containing therapy, along with a combination of TLD, you also have to give another dose of dolutegravir 50 milligram, that is double the dose of dolutegravir to achieve this therapeutic level. And following this, the treatment guidelines started recommending a combination of tenofovir, lamivudine, and dolutegravir, that is TLD, as a preferred therapy. Only in certain population, and particularly in children, particularly in women of reproductive potential, where at that time it was preferred to use TLD 600 because the data from Botswana have shown neural tube defects, especially in women who have initiated on the first trimester pregnancy. So this same group subsequently have shown very recently that when they compared the data of women who are initiated dolutegravir containing therapy, and when it's been compared with the non-DTG containing therapy, where there is not much difference in terms of any other neural tube defects. And following this, now it has been safer dolutegravir containing therapy even in pregnant women, and hence it become like a universal active regimen among adults, adolescents, and even in pregnant women. And why dolutegravir containing 2 NRTI therapy has been preferred? That is because, as compared to other integrase inhibitors, as you see in this particular slide on the advantages and disadvantages, where again, dolutegravir is being much superior as compared to other integrase inhibitors because it has been once daily and it's got a high genetic barrier to resistance, fewer drug interactions. You can combine with rifampicin, but you have to double the dose of dolutegravir. And so also can be co-formulated with other 2 NRTIs and currently being available even as generics, both as a tenofovir, lamivudine, and dolutegravir, as well as a bacavir, lamivudine, and dolutegravir. Also, you can give among women of childbearing potential. Thereby, today, a combination of tenofovir, lamivudine, and dolutegravir is a universal ART regimen. Can we give this in the same combination in second-line ART, where again, patients who have been failing first-line NRTI-containing therapy in this particular study called Dawning study, they were randomized to 2 different groups. One group received 2 NRTIs and dolutegravir. Another group, which is a comparator group, they received the standard 2 NRTIs and a protease-containing therapy. Again, in this particular trial, it's very clearly shown that a combination of 2 NRTIs with dolutegravir is been superior as compared to 2 NRTIs and a protease inhibitor-containing therapy among patients who have been failing in an RTI-containing therapy and subsequently been randomized to this particular regimen. Again, in this study, they optimize NRTIs. If they have used azacitidine first line, they used tenofovir, then they used azacitidine second line. So again, can we change from TLE, that is tenofovir, lamivudine, efavirenz, someone failing, to TLD, Today, the answer is, not been available. There are trials undergoing, but we can extrapolate based on this observational study called TNORS study, where it is a large observational study where patients who have been failing tenofovir-containing therapy, where their resistant testing was done and been documented in this TNORS database, where it's been found that in sub-Saharan Africa, almost 57% of the patients who are failing tenofovir-containing first-line therapy, they have K65 resistance mutation, which is a signature mutation for tenofovir. In our region of Asia, where it is around 39%. So that means someone who has been failing on tenofovir, lamivudine, and efavirenz, where you may have to optimize a second-line NRTIs to AZT-containing therapy, but you cannot change from TLE to TLD. That is because of these resistance following, tenofovir, which is already seen 57% in sub-Saharan Africa and 39% in our region of Asia. But on the other hand, someone who has already have a suppressed viral load on TLE, then you can substitute them to TLD so that they'll be on this universal ART regimen. If you don't have a viral load, can you change them to TLD? Right now, we do not have an answer, but there is a very nice randomized clinical trial which some of you have been involved called DEP study, where this particular trial is randomizing people who have been failing in NRTA-containing therapy into 3 different regimens, and one of the regimen is TLD. Even if they're on TLE on first line, they'll be randomized to TLD, where this particular trial will answer whether you can do that type of switch. Also, there is another ACTG study called TLD UPSO, which will also answer this critical question. So today, as part of the WHO guidelines, which has been adapted in most of our region, where we do have TLD as a first line, as a preferred choice, even on the part of the second line, TLD, is being, present. So that means TLD is a universal antiretroviral regimen in our region. And what about this prevention effect following initiation of dolutegravir-containing therapy? Again, I'm going back to the same study on single trial, which compared efavirenz versus dolutegravir. If you look into the viral load suppression, you can see very early viral load suppression before even 8 weeks among participants who have received dolutegravir-containing therapy, which is again the study on HPT and O52, where we have shown that someone who has got a undetectable viral load, the less chance of HIV transmission to the partners. Again, in our region, where introducing a combination of tenofovir, lamivudine, and dolutegravir, and there we are achieving viral load suppression much earlier, will also have enormous prevention effect. So our group, in collaboration with the Harvard CPEC group, also did a cost-effective analysis on this combination of TLD, that is a combination of generic tenofovir, lamivudine, dolutegravir, whether it will increase survival and decrease proportion of patients switching to more costly second-line ART, and whether it will be cost-effective. And when we did this analysis almost like 3 years back and shown that in GIAS, where we showed that at a cost of $102 per patient per year, a DTG-containing regimen will be very cost-effective, and this implementation would be at no additional cost to the national programs in 5 years. And we did this modeling for India. But now again, the cost has been further come down to almost like $70 per year. So, and also we concluded in that particular study stating that once this regimen is available generically, this should become the standard of care. So now it's been available through generic market as a TLD fixed dose combination. You can see this. We have got 4 or 5 different manufacturers been developing this, and it's been started launching from the year of 2017. Our clinic in Chennai, Voluntary Health Services, has an opportunity to initiate this combination very early in 2017 when it was launched. This is one of our earlier study and got published from our Chennai cohort, where patients who have been initiating antiretroviral drugs, almost 137 who initiated on TLD combination. Also, among patients of 145 individuals who are on stable efavirenz-containing therapy were moved to TLD. And patients who failed TLE were moved to TLD on 40 individuals. And also patients who are on second-line therapy with protease inhibitors with tenofovir, lamivudine, boosted darolutamide, 100 patients been moved to TLD. And also patients who are on alternate second lines with dolutegravir and lopinavir, and also among third line with darunavir and DTG, with 64 patients were also being studied. Also, there was a subgroup among patients who are initiating antiretroviral drug who had tuberculosis, where we doubled the dose of dolutegravir along with TLD in 56 individuals. And in all these individuals at 6 months of follow, they all had suppressed viral load, and it was been well tolerable, no one discontinued treatment. And we showed this finding, and we provided support for a large-scale transition to dolutegravir containing therapy as first-line regimens for resource-limited settings. So following this, there are several scale-up programs happened, and WHO implemented their guidelines. So this is a data where you can see, this is a much earlier slide from 2017 to 2018, where you can see this progress in transition to dolutegravir as a preferred first-line therapy. Some of those African countries and as well as Latin American countries among LMIC have been moved. And in our region at that time, it was being discussed as part of the guidelines. And subsequently in 2018, it started getting implemented. And almost 50% of those countries in LMIC by the year 2018, they moved a switch to DTG containing regimen as a preferred. And now by the end of 2019, treat all is being implemented entirely in our region. And also in our region, all the countries have implemented, introduced TLD in the guidelines, but it to be implemented. There are a few countries, particularly in my country of India, where very recently TLD is being introduced through the national programs. So we have a way to go to implement these potent TLD as a preferred therapy, and also among people who are already on TLE, move them to TLD so that it will be an universal AR2 regimen, in our regions. So we do have a WHO treatment guidelines update, where again, the current one very clearly states that TLD is an universal AR2 regimen to initiate among adults, adolescents, and even among women who have potential to become pregnant, intended to become pregnant, where TLD is a preferred therapy, and also among people who have got tuberculosis. Also, it can also be used in second line based on the pattern of the first line treatment failure. But what we are seeing now of late is the new era of weight gain following integrase inhibitors. So ADVANCE is a study which was carried out in South Africa, where they randomized patients who are initiating treatment in 3 different groups. One group received a combination of tenofovir, FTC, and efavirenz. Another group, tenofovir, FTC, and dolutegravir. And another group, combination of TAF, emtricitabine, and dolutegravir. Almost equal numbers of 351 has been included in this group. And this study showed that it's almost comparable efficacy among different arms. But when they did a sub-analysis, particularly about the weight gain and different groups, and it has been found in that, and you can see these on the left panel of the slide is among men, where again you can see these 3 different line graphs, where the green one is among participants who received efavirenz containing therapy along with tenofovir FTC, and the red one is on tenofovir FTC and dolutegravir, and the blue curve is among participants who received a combination of TAF, emtricitabine, and dolutegravir. If you see this, a combination of with the dolutegravir, with the tenofovir FTC or TAF FTC had a higher weight gain as compared to efavirenz. Again, if you see on the right side panel, among women, again, you'll continue to see this, and particularly with the regimen of TAF FTC and dolutegravir. So we looked into this in our cohort here in Chennai among patients who have been initiating treatment, where you can see this TLD on 348 patients, and also among we compared this among patients, this weight gain who were on TLE containing therapy, where we found that weight gain in both arms being seen, both among patients who are initiating TLD as well as patients who are among TLE. And when we looked into the BMI, where again, BMI gain was been statistically significant among patients who received TLD as compared to TLE among the first 6 months, and subsequently it was not statistically significant. Again, a very nice review has been published by Paul Sachs in Clinical Infectious, where he have very clearly have shown this particular weight gain among ART, it can be race and sex specific. Hence, we need to do specific studies in the context of TLD in our Asia Pacific region among patients who are initiating therapy or switching to this combination, particularly in the context of weight gain, how it leads to any other comorbidities. And now we are in this pandemic of COVID. I'm sure you all been managing patients who are living with HIV even with COVID. And our group, published this a review on the impact of COVID-19 among people living with HIV. And also, we also been involved in a study in Chennai among our people living with HIV and who had been diagnosed with COVID, whether any particular antiretroviral drugs, and particularly a combination of tenofovir, lemivir, and dolutegravir has got any protective effect against COVID. So we studied 80 persons who had COVID among 4,300 patients who came to our clinic or been called over the phone between March 2020 at the start of pandemic till November 30th, 2020. So among them, the 80 persons who have been diagnosed with COVID and HIV, 74 persons were receiving antiretroviral therapy, and among them, 81% were on the combination of tenofovir, lemivir, and dolutegravir, that is TLD. Hence, it very clearly shows that a combination of TLD has got no protective effect against COVID. 4 persons died of COVID in our cohort, and also we observed there is no difference in terms of disease progression as compared to non-HIV infected persons in our hospital. And this has also been well supported by other evidence from North America as well as from Europe. In summary, today TLD may achieve a goal of pill burden, high barrier to resistance, and activity against prior NNRT resistance to HIV. So thereby, TLD is an universal ART regimen. It's time to transit in our region to this more potent, better tolerable regimen. Also, people who are doing well with other therapies, particularly with the TLD in our region, should move forward to TLD because they are being less toxic, more convenient, and offer greater flexibility and result in less stigma, which is being caused by favirenz containing therapy. Also in our region, we need implementation studies. Particularly, we need to document the safety during pregnancy. Most of this data come from sub-Saharan Africa. We also need to study about this weight gain among this TLD in our region in Asia and Asia Pacific, and also about this long-term safety of TLD, particularly in the context of other comorbidities, and as well as whether this leads to any other comorbidities like diabetes and hypertension or worsening of any other comorbidities. With this, I'll stop my presentation. Thank you again for this opportunity. Thank you very much.